Hello and good morning. This is chapter 13. Very important chapter here. Not so long, but it talks about a lot about the reflexes and the nerves that will be assigned to the muscles that we discussed in chapter ANP1. Chapter 15 will follow after this, hopefully before the day ends. Here we go. Chapter 13. Introduction includes the fact that the spinal cord being the highway from the brain to the nerves or from the CNS to the PNS can be often subject to trauma and difficulties. This is what we always say, the information highway. Ascending pathways, descending pathways are always in line here and may be open to trauma or injury. I will teach you how to know if it's an ascending pathway, descending pathway, if it's a sensory or motor tract. We will learn the functions of the spinal cord, see the gross and microscopic structure here, and be able to trace nerve signals up and down the spinal cord. Spinal cord is very important for conduction. Nerve fibers conduct sensory and motor information, and goes without saying it is the part of the CNS, remember brain and spinal cord are CNS, that delivers sensory and motor information. It is also used for locomotion, especially when the pattern generators are used, sequencing your movement from left to right, your arm to your leg. It is also the center for reflexes, especially the spinal reflexes, which we'll learn at the later part of the lecture. Spinal cord is like a cylinder. It occupies two-thirds of the vertebral canal, and if you remember in ANP1, there is an opening if you look at it from the superior view, and that would be your vertebral canal. That's where your spinal cord passes through. Now, if you look at it on the lateral side, you will see the intervertebral canal or intervertebral foramen. That's where the spinal nerves come out. When the spinal cord produces spinal nerves on both sides, that's where it passes through the intervertebral foramen. This length of the spinal cord usually ends at L1. In an adult patient, it's at L1. So at L2 to L4, you don't see or you don't encounter the spinal cord anymore. So when we are getting CSF fluid, we usually go for levels L2 to L4. If you remember, if a patient is, for example, needing to be taken CSF, we put them in a C curve or head to knee position, and then we go in that area. We definitely sterilize first, and then we go into that area, and would be able to pull out CSF fluid for examination. From the spinal cord, it will give rise to 31 spinal nerves, huh? Like a 31 flavors if you think about it, Baskin Robbins. You will have the spinal cord divided into the cervical, thoracic, lumbar, and sacral regions. There's two enlargement there, and I'll show you the next slide. There's a cervical and lumbar enlargement. At the end, you will have the medullary cone tapering to the end of it, and then that's followed by many fibers, almost like the horse's tail, or the tail of a horse. That's why we call it coda equina. Hopefully we can get an example picture of it. Here you will see the cervical region, right? The cervical area. Cervix means neck. So here you see the neck, huh? Which gives uh, connection to the head. Then you have the thoracic spinal cord region, and then you have the lumbar, L1 to L5, and then you have the sacral. Here's the two enlargement, one at the cervical and one at the lumbar area, lumbar region. And here's the medullary cone. literally like a cone. And here are the hair-like looking or tail-like looking structure we call coda equina, tail of horse. The early anatomists, when they see these items during dissection, they call it what it is. If it looks like a triangle, they say triangularis or deltoid. If they see it's like the tail of a horse, they'll call it coda equina. And another point in the cranium, it looked like the saddle of a Turk. A Turk probably is another uh, one that invaded them, maybe Turkish saddle, and that turned out to be the sella turcica, which is a famous part of the cranium where the pituitary gland sits on. So yeah, that's how the early anatomists determined the names of these parts. And like I said, the spinal cord will give rise to many spinal nerves, and it will be made up of anterior and posterior horns, and therefore completing the segment as very effective and very uh, important parts of the spinal cord. Wrapping the spinal cord, just like it wraps the brain, are the meninges. The meninges help to keep the brain in a safety situation. It will be made up of a pad. The meninges are made out of a pad, just like a pad protects an item. Pad, I call it PAD because it stands for pia, arachnoid, and dura mater. Pia, arachnoid, and dura mater. Well, pia is one that is closest to the organ itself, in this case, the spinal cord itself. And arachnoid is after the pia, look like a spider's web, and then dura mater, which is the most outside. As we take a lumbar puncture, you will be piercing through all the three layers until you get to the inside. So here in this example, you will see the pia mater really closest to the spinal cord, and then you have the arachnoid mater, and then you have the dura mater. Here you see the spinal cord inside the vertebral canal or vertebral foramen, and then you see the spinal nerves coming out of the intervertebral foramen. The connection between two vertebrae makes up for an opening where the spinal nerve comes out. By the way, you know this is the cervical vertebra because only the cervical vertebra C1 to C6, okay, has this fork spinous process. This is the fork spinous process here, which is prominent in C1 to C6. Here's a picture of the meninges of the spinal cord, huh? And like I said, this meninges is like the surface of your skin. If this meninges gets inflamed, as in meningitis, then imagine the surface of your skin infected or at least like in a burn injury, even first degree burn, it would be very painful. So moving that skin would be something you wouldn't want anyone to do to you. In fact, if you do that to a patient, they would pull back their hand if it was on the skin, huh? So the same thing with the meninges. If it's inflamed and you move it, like for example, bending the neck area, right, in a flexion movement, then you would be stretching this meninges, this tender meninges, and the patient would resist you, right? That resisting movement is a positive sign, positive nuchal sign, confirmatory of meningitis. See, that's why they do that as a um, standard physical exam for suspicion of meningitis. You can also do that at the lumbar area where you make the person bend over, and that would also stretch the meninges and produce that pain which the patient would resist. So even if the patient is an infant, or yeah, an infant, he would naturally resist it if he is having meningitis. no doubt about it. He would not even talk. He can talk yet, but his actions will show you that it is positive for meningitis. Here's a better layout of the meninges. You have the pia right surrounding the spinal cord, embracing the spinal cord, and then which shows you the pia is the most inside layer, and it's almost like a skin to the spinal cord. This is what we can call the most visceral layer, more inside. And then you have the arachnoid, and then you have the dura mater. We said that in the early stages of pregnancy, especially in the first month, the nervous system is already developing, and it's important that the mother to be has a good amount of vitamin B and the B complexes. This is because folic acid, which is one of the most prominent uh, vitamins that you should have, if it's deficient, may lead to a condition called spina bifida. It's a congenital defect where the vertebrae fail to form a complete arch, and it will be protruding the spinal cord itself. So if you see that, it would end up looking like this. All right. Of course, there will be a lot of complications for this. So I always tell my students, if you are, and this is a fact, if you are a possible mother in any situation you are in, or if you are in a childbearing age, you should always be uh, equipped with a good multivitamins that would at least have some good vitamin coverage, especially folic acid, and also your diet hopefully would have that folic acid. A lot of other nervous system development rely on that folic acid. Not only will spina bifida be a complication, there's also some nervous system growth that can be stopped or halted if you don't have enough folic acid. Right? So that's very important. Now, going forward, we can see the cross section of the spinal cord. This is the spinal cord itself. Notice that in the brain, the gray matter was on the outside of the brain, most outside of the brain. And you can see that gray, more darker tone of the brain present in the outside layer. That's the gray matter. But in the spinal cord, the gray matter is inside. See? This butterfly looking part of the spinal cord is actually the gray matter. And the outside is made out of white matter. See, the brain is a flip flop. Even in the visual senses, it's a flip flop. Okay? The gray matter itself has a central core and will continue to be the most inside part of the spinal cord all the way to the end of the spinal cord. Huh? While the white matter, which is made up of columns or tracts of spinal cord, will make up for the funiculi or columns or tracts. And we'll discuss that as we move along later on. Spinal tracts. This will have ascending and descending sensory and motor spinal tracts. As far as that is concerned, when you say ascending, then you're getting information, you're getting sensory information from any receptors in the peripheral nervous system. And then they will enter the spinal cord and it will be brought up to the central nervous system, to the brain. So when it's going up to the brain, then it's an ascending track. And in many cases, ascending is carrying sensory information. So we can say that sensory tracts are ascending tracts. Or in another way, ascending tracts carry sensory information. When the brain has received the information, it will then decide, it will connect with other parts of the brain, the interneurons will take over, and the brain will come up with a decision. The decision that is made up will end up in a command or in a motor nerve impulse. That impulse will now have to be brought to the muscles or to the gland or to the organ that is target of that signal. Therefore, it will go down from the brain, spinal cord, and into the peripheral nervous system. So it's going down, it's descending. That's why descending are motor nerves. Motor means signals to the muscles to make movement, signals to the glands to make products. Okay, so it's a descending track, motor information being carried down. There will be parts, and so that's an easy way to remember that. Another way is how the spinal tracts will be named, and we'll show that in the next slides. By the way, the spinal tracts, if they use the spinal nerve, are mostly contralateral. They cross over, they decussate, and when they cross over, they usually affect the other side. So if you feel sensation on your left hand, that will end up going up the sensory tract and it will cross over to the other side to the right brain. And if the right brain starts a motor command, it will go down and cross over and stimulate the muscles of the upper or lower extremities on the left side. So it's contralateral. Ipsilateral is when the origin and destination of a track are on the same side. They don't cross over, which is more common in cranial nerves. That's very important. More common in cranial nerves. Here's another cross section of the spinal cord. And again, this is the gray matter, and this is the white matter. Now you see the red and green parts of the white matter, looking like a steak here. Makes me hungry. Now, the red is colored as the ascending tracts, which is sensory or motor, sensory. The green is colored as such, depicting that of a motor or descending. I would also mention some tracks are named by how they are assigned. They don't give a clue of if they're ascending or descending. And these tracks are the gracile and cuneate fasciculus. So gracile is more medial and cuneate is more lateral. When you see items in anatomy, always take note of how they look like. For example, here you have the cuneate and the gracile. Okay, which one is more medial, which one is more lateral? All right, or maybe which one is more outside, which one is more inside, which one is anterior, which one is posterior, which one is visceral, which one is parietal. That gives your memory a chance to label them and separate them so it's easier for retention. So we have CG here, CG, cuneate fasciculus, gracile fasciculus. I would mark them in my memory as cover girl, see, CG, edge girl, see. By doing that, it helps the memory to have a hold on that situation or picture. So by doing that, I will remember this as cuneate and gracile fasciculus, where cuneate is the more lateral part, gracile is the more medial part. And then there's another way of remembering this as we go along in the next slide. By the way, you will also see spinocerebellar tract, anterior and posterior. And you'll also see here the corticospinal tract, anterior, lateral, and there's also a tectospinal tract, reticulospinal tract, and two tracts of the vestibulospinal tract. Here's another way of knowing by the name that they have if it's an ascending or descending tract. For example, you have the spinocerebellar tract. In medical terminology, we say this as the AR is the suffix spinocerebellar, are both root words. Spino means a spine, and cerebellar means a cerebellum. So from there, it tells you that this tract, spinocerebellar, starts from the spine and ends in the cerebellum, which is up there. So that means this is an ascending tract. You see that? Just by the name itself, you'll be able to know this is an ascending tract. Therefore, this is a sensory tract. And it's on its way to the sensory homunculus. See? Uh, from there, from the cerebellum, it will go into the thalamus, into the sensory homunculus. That's what it means. If you have a corticospinal tract, cortico, that's the cortex. That's the cerebral cortex. And then spinal comes behind it. So that means it starts from the cerebral cortex down into the spinal cord. That means it's a descending tract. That means it's a motor tract. See? Vestibulospinal comes from the vestibular um, mechanism, which is your balance mechanism, down to the spinal tract. So it's a descending motor tract. Tectospinal comes from the tectum down the spinal. So it's a motor tract again. Right? Huh? So there's another one here. Spine to the thalamus. That gives you an idea. It's a ascending sensory tract. Okay, huh? That's an important way to learn if it's a sensory or motor. Now, some tracks, like I told you, may not help you in their names, and that's your cuneate and gracile fasciculus, like we mentioned before. Let's separate the cuneate from the gracile fasciculus. The gracile, which is the more medial, picks up signals from the mid-thoracic and lower parts, specifically below, not right at T6, but below T6, right? It will pick up signals for vibration, visceral pain, inside pain, deep and discriminative touch, receptors for your position. In whatever position you are, there are receptors that tells the brain how the body is uh, aligned or positioned or how the body is standing. Now, those are going to be serviced or picked up by the gracile fasciculus. By the way, proprioceptors are from proprioception, non-visual sense of the position and movements of the body, and they continuously send signals to the brain. That's why you're able to maintain your posture. The gracile fasciculus, below T6, while the cuneate fasciculus is T6 and above. The same information, but this is going from T6 and above. Okay, this will tell us that the uh, cuneate, it takes care of the upper part, while gracile takes care of the lower part. Another item I would want to mention is the ascending neurons or the ascending tracts are also divided into segments. And when I say segments, I mean order neurons. Neurons. It could be a first, second, and third order neuron, or it could be first, second, and fourth order neuron. Like this condition of the cuneate fasciculus, if I get my pointer, okay, it will have a first, second, and third order. The first would be coming in to the spinal cord, and the second order would be from the spinal cord leading to the thalamus, and the third order from the thalamus to the cerebral cortex. Okay, so if you have this uh, session, then you'll have an idea how the pathway is seen. Let me see if we have an example here. So here's a typical pathway in the CNS. From the peripheral nervous system, the nerve, okay, will get to the spinal cord. When it gets to the spinal cord, you can consider that as your first order neuron. If it climbs up the spinal cord, that can be your second order neuron. And then from the thalamus, it can become your third order neuron. So it's made up of segments. And why do we do this? We do this because in order to know what part, so we say we have a problem with the sensory, for example. But then the next question is, where is the problem? Is it in the peripheral nervous system? Is it in the spinal cord or in the brain? So if we divide them into order neurons, we can be more specific. If the problem is in the receptor itself, in the hand or in the muscle or in the part of the body where it begins, where the sensory begins, then your problem is in the first order neuron. If the problem is in the spinal cord, like a transection or an injury trauma in the spinal cord, making you not feel the sensation, then the problem is in the second order neuron. And if it's in the brain, more organic, a clot, a stroke, a bleed, then the problem is in the third order neuron. So when your specific problem is, you and your doctor will have a good idea of how to manage the patient, right? How to pinpoint and be right on spot where the problem is. Okay, huh? So remember that in the ascending tracks, you have first order, second, third order neuron. Sometimes there's a fourth order neuron. In the descending tracks, we don't use order neurons. In the descending track, we only use upper motor neuron, or abbreviated as UMN, or lower motor neuron, LMN. And you'll see that later on when we get to the descending tracks. Some diseases are specific for that. For example, poliomyelitis, we'll see later on, affects the lower motor neuron, LMN, and it goes all the way down to the specific muscle, many cases the gastrocnemius, which ends up in atrophy. Therefore, the limb. All right, we're back. We had a little bit of a glitch there. Okay, so let's go with the spinothalamic. The spinothalamic, from the spine to the thalamus, is part of the anterolateral system. It carries pain, temperature, pressure, light touch, tickle, and itch. Spinothalamic tract. Ascending, and it will have a first, second, and third order neuron. The first ends in the posterior horn from the peripheral to the spinal cord. The second order starts from the posterior horn and then decussates or crosses over to the other side. And the third order comes continues from there to the cerebral cortex. Okay. Um, this will end up in a contralateral stimulus to the other side, your spinothalamic tract. All right. Again, pain, temperature, sensation, vibration, sense. There's another one called the spinal reticular. This carries pain signals coming from tissue injury. First order comes in, just like the spinothalamic, and it immediately crosses over. Some don't cross over right away. It may climb up to the thalamus and then crosses over. But this one crosses over right away. The second order neuron goes to the opposite side, and then the third order neuron comes from the pons to the thalamus. Oh, wait, look at this. You have the pons to the thalamus like an add third order neuron. Therefore, this tract has a fourth order neuron because from the thalamus, it still has to reach that part of the cerebral cortex. And so the fourth order neuron comes into existence. Again, the second goes all the way to the pons first instead of the thalamus. And from the pons, it goes to the thalamus as the third order neuron. And then the fourth order neuron completes the path all the way to the cerebral cortex. That's the thalamus to the cerebral cortex. So there's a good example of four order neurons. Okay, four order neurons. The spinal reticular tract. There's a spinocerebellar tract, which is made up of first order neurons coming from the muscles and tendons to the spinal cord, and then from the spinal cord up, and decussates entering uh, the part of the spinal cord. The posterior spinocerebellar doesn't cross over; it stays on one side. The anterior crosses over, huh? And they will end up in the cerebellum. From the cerebellum, it may lead into the motor cortex. Let's try some descending tracks. For example, again, the descending tracks do not use order neurons. Huh? They use motor neurons. And we have upper motor neuron and lower motor neuron. The upper starts from the cerebral cortex or the brainstem, huh? And then goes down. The lower motor neuron can be in the brainstem or in the spinal cord, huh? Depending on what level. But the lower motor neuron goes all the way to the organ or the muscle that it's intended to stimulate. Let's have the first one. It's a corticospinal tract. The corticospinal tract carries signal from the cortex down to the spine. It can be made up of really coordinated fine movements. The pyramids are also tapped in. These pyramids are part of the medulla oblongata. The fibers of the anterior corticospinal descend in the same side, while the inferior, right, goes to the other side. It decussates. So there are uh, fibers that stay on one side and stay fibers that decussate. But in many cases, especially the main motor nerves, they can decussate and they will decussate. So in many cases, when you're trying to move the other side, you will have fibers coming from the contralateral, right? The ipsilateral is just a support segment that helps to maintain like a um, we call that an antagonistic effect. Antagonistic effect. Another tract is the tectospinal tract, coming from the tectum, the area of the midbrain, going down to the spine. Therefore, it's a motor tract. Tecto, I always remember tectospinal as tectum or turning, tecto turning, because it's used to move the head when you are responding to visual senses or audio senses. So if you hear a screeching of tires, you're in the parking lot and you hear a screeching of tires, the tendency is to look towards the source of that. And when you look and turn your head, your inferior colliculi for hearing ties up with your tectospinal to coordinate the movement of your head towards the sound. See? If someone calls your name, you move your head and then you tap your uh, inferior colliculi, and then you also tap your tectospinal. Same thing if you're following a moving object and you're locked on it visually. As the object moves, you also move your neck and head, then you're tapping your tectospinal. And by the way, that's your superior colliculi that helps to move with your motion. You also have your reticulospinal lateral and medial. This comes from the reticular formation of the brainstem. And like we said, reticular formation, if you remember, helps to reduce the pain. Uh, and it helps to reduce the pain that was first elicited and informed and was informed of the brain. Now, when that happens, you also use this reticular spinal for posture control. So when you try to compensate or respond to pain sensation, you will use your reticulospinal tract. It will have descending analgesic pathway. It will also have motor for the muscles to maintain posture. By the way, here's a good term to break down: analgesic. I would put a slash on an, which means without, and then ic. Ic means pertaining to. That's the suffix. An is, I'm sorry, yes, ic is the suffix, and an is the prefix, parts of a word. Alg or algesio is your root word. So you have a prefix, a root word, and a suffix. So when you describe this or give the meaning, it means pertaining to IC without AN, pain, algio or algesio, pain. So pertaining to without pain pathway, analgesic pathway. Okay, that's how you understand medical words. By doing this, you reduce the transmission of pain signals to the brain, and also reduces the pain signals as it goes down to the organ. So important thing is that you reduce the pain signals, and that's a sensory, by the way, and it helps you cope up with the pain. You'll also have vestibulospinal, which means it's for balance. Vestibulo is connected to your balance from the inner ear. Because of this, you can compensate, make the muscles compensate in order to maintain your posture. Poliomyelitis and amyotrophic lateral syndrome or scoliosis. No, amyotrophic lateral disease. Polio is caused by a virus, poliovirus. It's a big virus. It destroys the motor neurons in the brainstem and anterior horn of the spinal cord. You will have muscle pain, weakness, and loss of the reflexes. This will be followed by paralysis, muscular atrophy, and may also have respiratory arrest if it affects the upper segments of the spinal cord. This is a typical flu-like disorder, which you probably won't notice it, just a typical flu. And after the course of the flu, you will find that the significant part is having this prominent muscle pain and weakness, and also loss of reflexes. And before you know it, you'll end up in an atrophic muscle, atrophic lower limb muscle. And that would confirm the condition that you've been affected by the poliovirus, poliomyelitis. Virus is an oral fecal virus, which means you get this from a person who had the virus and has released it through the feces. And the feces, for some reason, got contaminated the water which the patient drank. So it's an oral fecal condition. That's why when they developed the vaccine for this, one of the methods was to give it as an oral drop because the a vaccine will trigger immune cells that are in the digestive system to counter this vaccine, which has uh, items that look like the virus itself. So you will train the white blood cells of the digestive system to be ready to counter this virus when it comes. So when it does come, the virus is right away controlled and destroyed. So therefore, it doesn't create the problem that it will do. The first vaccine was actually an injectable, which ends up in the circulatory system, providing training the immune cells to provide antibodies via the circulatory system, while the other one begins with training antibody formation in the digestive system. And of course, it will lead to antibody formation in the circulatory system as well. Amyotrophic lateral sclerosis, yeah, I was right, or Lou Gehrig's disease, also is a problem or condition of the spinal cord. Sclerosis is hardening, from the word itself. Osis means condition of. Some say abnormal condition of, and sclero means hardening. So abnormal hardening is scarring or ending up in a non-functional part. So when this happens to the spinal cord, you could imagine what the problem would result in. You will have some deficits. At the same time, the astrocytes fail to reabsorb the glutamate neurotransmitter and will accumulate. It will reach toxic levels, and the toxic levels will affect the body in a general sense. Muscular weakness, inability to speak properly or swallow properly, inability to move are signs of amyotrophic lateral sclerosis. In some levels, the intellectual function are stable. Huh? When you have this situation, it can be uh, a major factor to movement, and the person will not be able to move uh, as he usually does. Okay, huh? Let's go to the spinal cord. The spinal cord will produce spinal nerves, huh? And will produce ganglion and will produce segments of the spinal cord leading to the plexuses. We will study the plexuses after this. So again, you have the spinal cord producing anterior and posterior segments, and which makes up the spinal nerve. The spinal nerve are made up of bundles of fibers, nerve fibers itself. Huh? You will also have arterial and venous vessels supplying this spinal nerve. That's why it's able to be sustained. Huh? Spinal cord communicates with the rest of the body through the spinal nerves. Huh? The cord-like segment, which has afferent and efferent motor fibers. The spinal cord will form ganglia and parts of the nervous outlay. There would be the endoneurium, perineurium, and epineurium. The endo is a covering for the loose connective tissue, while the perineurium overlaps the squamous cells. It's also a covering, but more of the outside. Endoneurium is more visceral or internal, and the epi connects the actual nerve to the other parts of the body, and therefore puts it in a stable position. So it won't move a lot. That's why it stabilizes it with the outside tissue. The nerves would carry sensory, afferent, and motor efferent signals. Sensory coming from the outside to the brain and spinal cord, and motor from the brain and spinal cord to the muscles and glands or target organ. Mixed nerves would mean it has both afferent and efferent fibers. A ganglion is a cluster of neurosoma. It's almost like a station, which makes the signal stronger and makes like a gatekeeper. Sometimes the signals need to be stopped, and a ganglion is a good point to not make the signal process further. So ganglions are also important parts of the whole network. Here you have a ganglion, where you have a lot of root ganglia, right? And you have the fibers passing through this ganglion. Again, it strengthens the signal. At the same time, it's a way of either processing the signal further or not processing the signal further. There's 31 pairs of spinal nerves, 8 for the cervical, 12 for the thoracic. You have 5 for the lumbar, 5 for the sacral, and 1 coccygeal. Here's your 31 pairs. Here you will see the spinal cord and then the spinal nerve coming out of that area. So if you're looking at it this way, this is the posterior part or dorsal part. This is the anterior part. Here you'll see the dorsal roots, rootlets we call them, and which leads to the roots itself, dorsal root. And then it will reach the ganglion, dorsal root ganglion, and we call DRG. Here you'll see the ventral roots leading to the VRG. It's a ventral root. Together they will end up in a spinal nerve. The DRG sometimes is closest to the spinal cord, especially in um, fight or flight situation or sympathetic nerve ganglions. They usually are closer. The parasympathetic, the ganglions are found closer to the organ, closer to the organ. When we get to chapter 15, that's where you will see the sympathetic and parasympathetic ganglions, and you will have a good example of it. Spinal nerve is formed from two roots. We say the posterior and anterior roots, and they will end up combining to form your actual spinal nerve. Here you'll see the dorsal and ventral roots making up the spinal cord, spinal nerve itself. This is the cervical spine. Later on, it will form the cervical plexus. You can see here the dorsal and ventral rootlets. Dorsal means it's from the back, from the posterior. This is another picture of the cauda equina. Over here, you see the spinal nerve roots, and the spinal nerve roots would lead to spines coming out, cervical area, thoracic area, lumbar, sacrococcygeal area. The spinal nerve roots will further combine and give rise to what we call the plexuses. Uh, the plexuses that will give us the nerves that we need later on. Right, and this shows you the intervertebral foramen where the spinal nerve exits. Intervertebral foramen, Again, the dorsal root ganglion, the ventral rami. This takes care of the stimulus that exists in the area of the thoracic. It could be the intercostal muscles. It could be the glands. This also shows you the dorsal ramus. Rami is plural for ramus. This is a top view of the spinal nerve being made up of the anterior and posterior roots. Also shows you the spinal cord inside the vertebral foramen. Okay? And this would be the space where you can release the spinal nerve. This is your intervertebral foramen between vertebrae. Here's a picture of your dorsal ramus and ventral. Okay, gray ramus, a ganglia close to the spinal cord, and white rami, or ramus for that, plural. Here's an actual another human remains example of the spinal cord. See how the rootlets come out, right? Almost like telephone lines, right? And they will combine to form the spinal nerve. By the way, here's the arachnoid matter, and here's the dura mater for your example. Another view to it, in the area of the spine, you will see branches of the thoracic coming out to stimulate the intercostal muscles, right? And we use that for breathing, right? For regular, normal, or forced inspiration or expiration. Chickenpox is a virus that can infect humans, usually seen in childhood. Some of you may not have had chickenpox because you had a vaccination before you were exposed to any chickenpox virus, but otherwise, it can be acquired by being exposed to a person who has chickenpox. This is chickenpox is a named also as varicella zoster. Varicella. Okay. Smallpox is variola, just for your information, which should not be uh, seen in our mainstream cases. They said that it's already been eradicated. But when the condition goes down, some cases of smallpox emerge, maybe even outside of the U.S. usually. So varicella for chickenpox and variola for smallpox. Chickenpox is also seen as a dermal manifestation or a skin manifestation. The virus can be cleared, meaning the virus is taken care of by antibodies that the patient forms. But some of the virus can stay in the posterior root ganglia. And when the immune system of the patient is down, this viral load or this virus condition can surface again. But it would surface as a condition of shingles, herpes zoster. It will go down the sensory route and, in fact, be almost visually prominent on the skin. You'll have some redness there, some pain right in that area of that redness, showing you where the nerve conduction is delivered to, and that's where the pain would be felt. This could be seen usually after the age of 50, where your immune system can be detrimental. There's be episodes of low immunity because as you age, your immunity decreases. Like we said, this can once active, you're then active for chickenpox virus, right? And it gets better when your immune system, or when you have some rest, or when the immune system has a chance to recuperate. Right? Again, this is from chickenpox virus. Okay, from here we'll take a break, and when we come back, we'll discuss the plexuses, the nerve plexuses, the cervical, the brachial, the lumbar, the sacral, and coccygeal plexus. Okay, we'll take a break. And then we'll continue after that. All right.